all good to go.
Okay. Thanks for the introduction, Kirsten, there. As she said, I'm going to be doing an essentials of medical documentation. Please feel free to pop questions in as well. If there's anything that you're kind of worried about or want to ask at the end as well, then feel free to do so. So just a quick overview about what I'll be doing, what I'll be talking through today. So we'll be going ward round notes, a bit about death certification and kind of the paperwork and things behind that, TEPS and DNR, and then some scenarios with some questions that hopefully will spark up a few things. Okay. So as I said, ward round notes, kind of basic, like every time we kind of see patient things, we should always be writing in their ward round notes, and those are kind of really key information for other healthcare professionals as well as ourselves, and kind of reminding ourselves what we've done for that patient. Normally when you see that patient, you should be writing kind of what you're doing in that. That's not only for us to kind of remember what we've done, but also if things go wrong and we need to reference or explain what happened in that, and it's a good documentation to have, and it's on a piece of paper. When we're writing with those, I think different trusts have different things. So at my trust, we are online now, so you don't really need to remember to write in black ink, and it's all typed as with the date and time. But for paper notes, make sure you're writing with your black ink. Tend to set out with like a date and time, where you're based, so the ward and the hospital, and then it's always a good idea to write who was in the room at that time. So kind of all the professionals. I know it's quite long to kind of do that for everyone, but it's best practice to do so. We write ward round notes. A good way that kind of I got taught was you write who's in the ward round. If it's a consultant X, then you'd write consultant X, and then you go through their news scores, their bloods, any kind of recent tests that they've had, and then you can write what you talked about with the patient and any examination as well. When you're writing, just remember not to use kind of any abbreviations and things that could be interpreted in different ways. Chest X-ray and things are fine, like CXR, but I wouldn't write things that other people might not know. It's always good practice to write at the bottom kind of the date and time of your review, and then also sign with all your date and roll. So a good ad is your consultant X, date and time at the top, then on your examination, your review, your plan, and then you can sign it at the bottom with your entry. If you're using 2 continuation sheets, it's always best to write continued on next page, so that people remember to look at that, because it's quite hard when you're busy. It might not be seen quite kind of that you're carrying on with your review and there's notes on the back, but it signals to other people that this isn't quite finished and there is also something on the back. As I said, when you've got online things, it's a bit easier because you already have the date and time. It'll have your name written on there, but always kind of write on paper if you need to. You need to write kind of your grade, your role and things, but I'll kind of come to that in the next one. Grade and role, so FY1 consultant, I think that's a really good thing to have at the bottom of the note. You know who's written it. As I said, a lot of people write in a patient's notes, and it's sometimes hard to know who's written what. You'll see nurses write it, you'll see physios, OTs, and I'm sure you've all kind of seen that on your placements and things. And it's always good to have an idea of who's written that note, so you can kind of gauge their understanding and what kind of advice they're giving based on that. Another thing, C number, which I actually found quite hard to remember at the start, but now it's kind of rolled off the tongue. And you just pop that at the bottom, as well as contact number if you're on call. I think it's a really useful thing when you're writing notes to write whether you've seen the patient or not. So if you're covering on call, write an on-call review at the top so people know that you might not know that patient so well. So you've gone through the things that are important for that review. And also know that you might not see the patient again, and you've left your contact number if nurses have questions or other people have questions. So that's kind of ward round notes. In general, I think being on placement as a medical student, I saw it done a lot. I was kind of used to that. The main things I would say is kind of having those conversations with families documented. So if you're having sensitive conversations about test results and things, making sure that you've written that down on the notes so that next time, if a consultant sees them next day and you're not there, the patient already knows about X result of a suspicious lesion. And if they don't, then also writing that they don't know that and you haven't explained it, so that they can then say it or specifically tell it to them in a sensitive way. What I found useful is, as well, is writing down kind of DNAR conversations and things clearly. So you've had with kind of what you've kind of explained to the patient, what you've explained that it is, and making sure that they have an understanding, and any questions they ask, if they had kind of confusion about it or whether they were resistant to having that. It's always useful for other people to go back and think, actually, yes, we need to have this in more of a depth. And it also means that people aren't repeating the same information and kind of stressing families and patients out by doing that. So yeah, one thing I would really recommend is kind of getting into a habit of doing that quite regularly and writing kind of family conversations as well as just your ward round notes and things. So that's kind of ward round notes, I think, in a summary of that. The next kind of thing that I didn't really have much experience of before going to F1 was death certifications and things. I know in OSCEs we're asked to write them, and you can kind of get a bit of an outlook as to how that's done, but I think it's the whole thinking behind it and things. So you might get called on your one call, and the nurse will say, this patient's died, can you come and verify? And it's really important to check with the nurses that, do they have a DNAR? Are they sure they're not for resus? In most cases, the nurses will have checked that, but I think it's a really good thing to just double check when you're on call. You're not aware of all the patients and their situations, and having that confirmation, especially when they ring you, can then kind of let you prioritize where this comes on your jobs list. You can verify anyone. You don't have to have seen them while they're alive. And verification is the process of going to them and listening to their heart sounds, listening to their lungs, feeling for a pulse, and checking for kind of a pain stimulus response. That's all as well documented in the notes, so that when the doctor who does know them can then certify the death with the time. And it's really useful to have that on there, so then you reflect back on it and you can use that time on the certificate itself. Normally at my trust anyway, the medical examiners will get in touch with the ward. They'll kind of ring you and ask for you to come and do this certificate. And for that, you need to kind of have seen the patient alive in their last 28 days of illness. That was prolonged from 14 prior to COVID. And you need to have checked that kind of you've seen them after death as well. And you don't have to have verified them, but you might have to go to the morgue and just see them as well, to make sure you've seen them before death and after death, so you're confirming that it's the right patient that you're writing the certificate for. Something that I kind of realised later on as well was crem forms and cremation forms. So some patients obviously have a burial and some have cremated. And for that cremation form, you need to check that there's no kind of ICDs or implantable devices that the patient might have, as it's a health and safety risk. So things to look for are people's chest x-rays. Have a look if there's an ICD on there or a pacemaker, and those need to be removed before cremation, and you sign a form, and that will kind of all happen. If they do have one, you just tell the medical examiner and they'll help you through the process of things. And just kind of in general, they're really, really helpful when you've got questions about death certificates. Kind of going on to that, you might be wondering, right, 1A, 1B, 2, medical examiners will help and suggest things. At my trust, they kind of write in the patient's notes once they've seen that someone's passed away. They'll write in the notes a suggested cause of death. But it's really important to check with your consultant that's looking after that patient, to make sure they're happy, because although you're signing the death certificate, you do write the consultant's name on as well. So it's good to see that they're kind of, the ME thinks this and the consultant also agrees. Other things in terms of reporting people to the coroners, there's kind of unknown cause of death. So we're not really sure why this person died, or it was a violent death, or they had an inpatient fall and you think that's contributed to their death, or so there's quite a few things that you refer to coroners, but people normally guide you to that. And I think there's a good link online on the internet about who should be referred to coroners and things, but it will never be just your decision to decide that or think about that. So I wouldn't worry about that too much. So as I said, cause of death, you've got the whole death certificate, which is part 1, and then it's 1A, 1B, 1C. And 1A is what you think directly caused the death. 1B can lead to 1A and 1C can lead to 1B. But part 2 is anything else that kind of contributed but wasn't directly affecting it. It's quite hard to think about that until you get kind of a case scenario. But normally 1A is kind of quite clearly the cause of death, so urepsis, or kind of, you can have frailty of old age as long as that person's over, I think it's 80. But there's very specific sets, 1As, and there's a kind of a document online that you can see what's accepted for that. They also don't like you to use abbreviations, so like hypertension couldn't be HTN, it would have to be hypertension on the death certificate, but so write everything in full and capitals. There's 2 parts to the death certificate. As I said, the patient gets kind of the bigger part, which has when you last saw them alive, the day they died, time, and their causes of death. And there's just a counterfoil on the left-hand side, which is a book for the hospital to have and kind of keep an eye and track on the registering of death. So that you can use abbreviations on that part, but the big part of the death certificate has to be full words. The other thing I'd remember about when someone dies on your ward is that the GP also needs to know, and that's done via ICE normally. If your trust uses ICE, it's just a kind of a discharge letter, but a death summary. That goes straight to the GP. You kind of outline what the cause of death is, give them a bit of a synopsis, and that notifies them that their patient has passed away. And yeah, as I said before, you write your name on the death certificate, so and also your GMC number, but also your degree, so whether that be MBCHB or MBBS, and then that's all kind of sent away as a pack to families and things. So there's an example. You kind of put the name of the deceased and the death that it was stated to you, and then you last saw them. So that's the other really important thing about when you're writing ward round notes, to have the date and time. So you can write these things and you can have a look. Actually, yes, I saw them a week ago, and this is how I know that I've seen them, because you end up seeing so many people that it's hard to keep track of when you last saw someone. And then 1 to 4 and A to C is just a circle. You just circle around what it is, and normally it's a 3, which is post-mortem not being held, and you see normally an A because you're seen after death by me, because you normally go to the morgue and see the patient. So it's normally a 3A, but obviously if that changes, then it changes, and it can be changed accordingly. And then 1A, 1B, 1C, 2, and then at the bottom, your name, your qualifications, and consultant responsible for the above patient, and you'd write your consultant's name. Your residence is also normally your hospital, so whether that be kind of RVI, so Royal Victoria Infirmary, and then ward, whatever ward you're on. So it's not your home address, it's where you work. So that's kind of death certificate. Another thing, as I said before, was cremation forms. So that's when people are cremated rather than buried. And it comes from the funeral directors will ask for this, and the family will have said, actually, I want my loved one to be cremated, and the funeral directors will get in touch with the medical examiner's office and ask for you to fill that in. And that's the bit that people get paid for by the funeral directors. So the cremation form is a paid thing. The family pay for this. It just includes a small kind of synopsis about the patient, what went on in their admission, their job, causes of death, and then it's also that form about no implanted devices or anything like that, and means that there's no health and safety risk. That form is a little bit longer than a death certificate and does take a bit more time, but it's quite self-explanatory. And yeah, and you can have a look at those online as well. So that's kind of death certificates and crem forms in a whirlwind. I think one of those things that it's quite formal. I think you feel like you're writing quite a formal document, and it can be quite nervous as kind of an F1 and things, doing it for the first. A lot of the medical examiners are normally really, really helpful, and you won't feel. Hopefully, you won't feel too. It won't feel too daunting. So TEP forms. I know people have different trusts have different things, but in my form, it's a TEP form. Treatment escalation plans, and it helps us decide whether a patient's kind of up for level 3 care or level 2, or whether that's not appropriate and a ward-based ceiling of care would be better for that patient. It also allows us and reminds us to kind of communicate these with patients and ask them sometimes if they have any ideas, because sometimes people will say absolutely not, I don't want to go into ITU, and that is their wishes and they have the ability to make those decisions. Actually, it reminds us as clinicians to ask people who have to fill in forms like this. It also includes whether the patient has capacity and lasting power of attorney and advanced decisions to refuse treatment and things. So it's quite a good one point of call for when patients are a bit ill, and if they're filled out really well, that can save you so much time when you're in kind of an on-call situation and you've never met someone before. It takes things, as I said, level 2, level 3 care. Level 2 is like one organ support, level 3 is multi-organ support. So things like level 2 could be NIV and CPAP or dialysis, and that's fine by itself. But if there was more than that, that patient might not be up for level 3 care. It helps with IV antibiotics. Oh, the slide's not moving for people. Can everyone else see the slides, or? Oh. Let's try a different way. Oh, they've moved now. So can you see that TEP form there? Yes, okay. Let me know if when I move to the next one whether that works. I'm sorry. I can get them to try and send them out, and I think on the live screen it will be recording I can see. But if you want me to go back towards the end, I can kind of whiz through them again. But as I said, thank you. So TEP forms help us decide whether IV antibiotics are appropriate, IT, kind of those things as well. It can be signed by an F1, so we can sign that we've had that communication, we've spoken through that form with them, and this is what the patient would want. But it's normally best to have it endorsed by a consultant, and they can just sign on the bottom saying they're happy for what's appropriate, what we've discussed with that patient. Always update families with those decisions, kind of discuss with them. I know at the end of the day it is a medical decision, but people will be a lot more thankful if you have those discussions when people are well, rather than when they say, actually, I've never had, so no one's ever spoken to me about why I wouldn't be for ITU, and now the patient's really sick and ITU need to be called because the family are a bit concerned about why they haven't. So just going on to the next form, can you see those pictures of the kind of forms? I hope so. Not heard anything different, so let's go with that. We can see it. So this is from Northumbria Trust, which is where I work at the moment. So this is the TEP form that we use. You write kind of the performance grade, their main diagnosis, which could help with outlining why you've chosen the next things, whether they're full active resus or active medical management, but with the limits set out below. And then it kind of says, is the patient for... What's going on? Gosh, not very good at this. Any chance you can see that? Maybe I have to stop presenting them and re-presenting them each time, which isn't ideal. Sorry. Can everyone see that now? Okay, so those are the pictures of the TET forms that we use. So you kind of tick through and see, that's great, and see, I'm sorry about this, and see what is appropriate. And it's, on ours it says is oral antibiotics therapy, IV antibiotics, IV fluids, and blood transfusion. So they include those things. I'm not sure whether all trusts do that, but those would be the kind of things that you're thinking about when you're discussing a treatment escalation with a plan with patients. And also then it says kind of has it been discussed with the patients, and if it hasn't, then do they have the capacity, and then it kind of works through all that there. I'm going to stop presenting and then present the next slide if that works. Okay, so respect forms are kind of a recommended summary plan for emergency care and treatment. They're something that you get taught on ALS about. That's that purple form. They're a nationwide form, so that's for all trusts, regardless whether you work, you can always use a respect form. And it's kind of for future emergencies, similar to a TEP, but so TEPs can be kind of changed by each trust, whereas respect forms are nationwide. Just a little bit on that, because we don't actually use them at our trust, so it depends where you go. So more about a DNAR in general. A DNAR, I'm sure we're all aware, temporal resuscitation, normally involves kind of multiple conversations between families. So that's why I was saying in the ward round notes and in your notes in general, just having, if you discuss that with a patient or discuss it with the family, and it's good to write those so people can then pick up on your discussions and pick them up at a later date. So if you broach it with the family and then you decide actually they want some more time to think about it, and that's documented there, the next person that comes along could say, oh, this person's already had that bit of that conversation, I can just pick it up from there. It is a medical decision, so we can decide as doctors that it wouldn't be appropriate, but patients can express their wishes as well. So if someone says to you, I really don't want CPR, then that would be their wish if they had capacity to make that decision. As an F1, you can sign one, but I don't think it's indoor or illegal until a consultant or a registrar has signed that. So even if you do sign one, someone else might say, actually, I don't feel comfortable not doing CPR on this patient, so we're going to do CPR. It can be revoked as well. So say, for instance, a young patient doesn't want CPR and they put that in place and then they change their mind and we think it's appropriate for them to have CPR, that can entirely happen. You still keep the copy, just a big cross through the document. Make sure you sign that cross and you date it and you time it, and write a little conversation. Patient accept that they want CPR now, have capacity to make the decision, and it is appropriate, kind of a little synopsis about why you've done that. And they last for a year, so a lot of people that you meet might have community DNARs, but they haven't been signed for the last year. That effectively isn't in date, so it needs to be signed at the earliest opportunity by your consultant, or flagging that to someone more senior would be very appropriate. And there's that DNAR, you can all see that. So this is kind of the ones that you get at the hospital. You put all the patient identifiable data to make sure that's the right thing you're writing it for, and then why you've signed that CPR, why you've put in place. So there's no reliable chance it could succeed, but they have capacity to refuse, and you can work through those things, and then make sure you sign the senior the responsible clinician will sign in that bold box at the bottom. And then if in a year's time someone else says, actually, yes, it's still in date, the patient still wants it, they can sign in that bottom kind of red and lighter red box. They don't need to write the whole form again. And as with all these things, black ink, capital letters, making sure it's legible, all really good things to do when you're doing that. So we've got a couple of scenarios and questions to go to. let's pop that on there. So can I do a poll? Okay, so family conversations included in the notes and kept separately. What does everyone think about that? Yeah, nice, easy one. False. You keep them in the notes. They stay with the patient. They'll get scanned. If they're paper notes, they'll get put on their records. So it helps GPs and people. And also, like, if they come back into hospital at a later date, you can always look at those again. So they're included in the notes. Write them in the notes always. Make sure it's accessible for all healthcare professionals, so everyone can see them. And then the next one. I'll stop sharing again because I've probably. The next one is when a patient dies, it should be included in their notes. We're getting about like 10 responses, so I'll wait for a few more people to. Yeah, so it should definitely be included in their notes with the date and time. So the documentation might sound something like this: patient identity confirmed, no response to pain or voice. And then you put something like heart sounds listened to for so many minutes, lung sounds listened to for so many minutes, no response, pupillary reflex tested for, and then you'd say kind of patient X died at X date on X time, and then rest in peace, or whatever you think appropriate. So the next one is when a patient dies, their time of death is, and then all the options there. Let's just put them on here. Yeah, time verification ends. So once you've finished your whole examination of that patient, that's the time ends. I remember someone when I first was saying that you might get called in the middle of the night when you're in a night shift, kind of 11:30, let's say, and the nurses are saying, yes, this patient's died, they had a DNAR, it was expected, can you verify? And what can be quite stressful for families is that if the verification doesn't happen on that day, the time of death will then change to the next day. So if you kind of don't go by kind of the end of the day, then obviously it would be an entirely different day on the death certificate. And sometimes it's not possible, and sometimes you get so busy that this is lower on your list. But I think it's really important to think about with patients that could die overnight and getting called about verification. So the next one is whose name should be included on the ward round. So I'll just get that. a bit more of a mix there. Most people went for the right answer. Everyone present in the room at the time of review. So even if there's kind of trainee nurses or medical students or HCAs, anyone who's in that room at that time should be included on there. Some things that I didn't probably appreciate before I started was that if people say that something happened, that ward and said this, or this doctor said this, and you know who's in the room and who was present at the time. So then you can look and you can kind of speak to those people and check that everyone heard the right thing and was aware of what was going on. So it's good practice to involve everyone for that reason as well. And then this is a bit, probably not a poll one or anything like that, but it's just a scenario to kind of speak through. Let me do that. So she's Mrs. June, 87-year-old lady. You last attended on to yesterday. She has advanced Parkinson's, admitted 4 days ago with aspiration pneumonia, and unfortunately it didn't respond to antibiotic treatment, and the decision was to palliate. She died last night, and it was verified. And what would you kind of think? Any suggestions about what you'd put on the death certificate? And I'll answer that question in just 1 second. That's being put on there. Any suggestions about a 1A, what you think caused her death? Yeah, that's probably what most people would say is aspiration pneumonia. You kind of treated that and they didn't respond to antibiotics, or we're assuming that she was dying from the infection. I think that's probably fair. So that would be my 1A. Anything in your kind of 1B or 1C or even 2? Yeah, I think you wouldn't be wrong to do aspiration pneumonia secondary to advanced Parkinsonism, yeah, because that could impair your swallow and cause her to get the aspiration pneumonia. Some people might say, your consultant might say, actually, we don't want it as 1B because it could have been something else. She could have literally choked and had a poor swallow anyway. So some people would say to put it in 2. It's very variable. You'll see some consultants that will put it as 1B and some who will suggest to put it as 2. But it's always kind of their decision at the end of the day. But yeah, kind of thinking along those lines, that's perfect. And just to go back to the question about medical students or specify names, I tend to specify names, but a first name, and then I'll just put 50-year medical student or 4th-year medical student. But sometimes when it's so busy and there's like 6 people on the ward round, it gets long. So you can just write 50-year medical students as long as you have kind of the professionals and the people that are on the ward all the time. Then I would say that's fair enough. So just in terms of, kind of wanted to keep it nice and brief, keep it up to date, kind of keep all the pertinent information, because you can sometimes get bogged down in things and kind of overcomplicate things as well. So I just wanted to have what I would have wished I'd knew before I started. But any other questions at all, and there's a feedback form on there, that would be really great if you could fill that in and give some feedback for us. So someone's just asked, when doing a death certificate, do you have the chance to discuss 1A? Yes, so you should always discuss. So when someone dies on the ward, the consultant will be aware that they've died, and you say, I'm just going to do the death certificate. This is what the medical examiner is proposing for 1A, 1B, 1C, and 2. Do you have any suggestions, or would you like me to change it? It's their decision what's on the death certificate. You can propose things, so you could say, I think this lady probably had an aspiration pneumonia. I was thinking about putting that for 1A, and 2 is Parkinson's. Do you think that's appropriate? And sometimes they'll say, yeah, of course, whatever you think, or they'll say, actually, no, I think Parkinson's should be in their 1B. But yeah, make sure you are discussing things with the consultant before you fill it out. And the ME office is normally open like all day, so you'll end up doing a ward round in the morning and then going and doing that job later in the day. It doesn't actually need to be done like first in the morning. Hope that makes sense. No worries. No worries. Thank you for coming. Thanks for listening. if anyone has any other questions, I'll stay on for a bit longer and just pop that back, and the feedback would be great, please. Any advice for night? Do you know what? Actually, they probably weren't as bad as I first thought. At my first nights were surgical nights, and I remember being like, gosh, all the surgical registrars aren't going to answer their phone and it's going to be really scary. But I know people bang on about this in med school as well, and I was like, gosh, it's just like all they ever talk about is A to E, but it does always save you. I think if in doubt, I think when you get a sick patient, an A to E is always the first thing I do, and no one's going to shout at you for starting antibiotics because someone had a temperature, they were tachycardic and hypertensive. That will never be the case. They will just stop them the next day if they don't think they're appropriate. Yeah, it's always hard to get into the routine of nights as well. And sleeping and things, but once you find you've done the first one, then the next come a bit easier. But yeah, and if you're ever unsure, I would always ask. I'd always recommend asking people. People won't shout at you down the phone for asking for advice about a sick patient. And most people who are sick and you do need advice on, most of your seniors will be like understanding about things. But anything in particular about nights that you wanted advice on? Or just in general? Yeah, I think that's fair. Yeah, I think you're also in a kind of a back of house team at night, so you'll always have like a registrar or an F2 or someone to ask things to. So yeah, don't be scared to ask people questions, and don't be scared to get things wrong. It happens, and yeah, you'll be fine. You'll all do great. No worries. No problem. I'd say enjoy your free time. You've done the hard part, you've done the finals, you've got the knowledge. I think yeah, just spend time with people like friends and family, and just enjoy yourself. I wouldn't say you need to prepare for F1. I think I stressed about it quite a lot and actually found that the only way you really learn is by doing the job and making those mistakes. So yeah, just kind of enjoy your last few days at uni and hang out with people and having your free time. I think as well, if you're moving cities and you're moving to be in a different place, kind of that you were used to, or that you go have a look around the city, so you're a bit more familiar with it. Speak to kind of other people that are working in that trust and have a see what they say about it. But I think it's absolutely fair for you to just kind of enjoy that time and relax. there's no more questions and everyone's quite happy, then we'll just end it here and I'll end that. Thank you.